I'm Dr. Lily Han. I'm one of the Cook Children's Physician Network providers, and I am also an obesity medicine specialist. I am excited to be a part of our new Prosper Cook Children's Adolescent Bariatric Program, and I'll be serving as the Obesity Medical Director of the program.
Hi, I am Dr. Kanika Bowen-Jallow. I am a board-certified pediatric surgeon. I'm also the medical director of the bariatric program and also the medical director of surgical services at Prosper at Cook Children's.
Genetics play a very prominent role in childhood obesity. Genetics probably accounts for 40 to 70% of the obesity. Maybe 30% is probably environmental, and the remaining may be psychological factors. And that we have identified many different genes that code for obesity. Sometimes it is a monogenetic obesity. It's just one chromosomal aberration. Sometimes it's polygenetic. It's multiple mutations that act together to create a profile of obesity. So that is important to note. Now, just because you inherit the genetics of obesity, it does not mean that you are destined to be obese. We actually have some control with regards to what genes are expressed, and that's where our environment can be very important. But it is important when we talk to our families and patients to let them know we're not playing the blame game. There is a genetic reason that their body has a desired set point or a desired weight that it wants to be. And our goal with treating obesity is to maybe change that set point with what we can do and work together to just have our children reach and become healthy young adults, ideally without obesity. How genetics play a part into obesity often has to do with where we have our set with regards to hunger, where our hunger levels are set, what type of cravings a person has can be attributed to genetics, what it takes for them to feel full or have satiety, and then also their energy metabolism, or basically when people are burning calories, a lot of that is hardwired by your genetic code.
And just to add on to what Dr. Han was saying, you can't outrun your genetics. And so even in my instance, I have high cholesterol. I do my diet, I do my exercise, it's going to hit eventually. I think it's very important that we let families and patients and physicians know there's such a heavy part of genetics that's involved in this, that no matter what you do, it is what it is. And so we should all have the tools to be successful in life and lead a long, healthy life. To talk about the age and BMI requirements, I'd like to start off with the current recommendations by the American Academy of Pediatrics. In 2023, the American Academy of Pediatrics published a set of guidelines for the treatment of children and adolescents with obesity. And in these guidelines, they recommended that our PCPs, our pediatricians, and other healthcare providers at the age of 13 refer those patients with severe obesity to a pediatric bariatric center. So I think that's very important because the American Academy of Pediatrics guides what we do for children. And they have now realized that this is something that we need to address and address now. And so the current recommendations for the BMI are a BMI of 35 with a comorbidity or a BMI of 40 with no comorbidity. And comorbidities could be anything: polycystic ovarian syndrome, diabetes, hypertension, sleep apnea, all of these things that we're currently seeing in adolescents, and the list goes on and on.
The data that came from the AAP is based on 13 and up because that's all they have the data for. However, the American Board of Metabolic and Bariatric Surgery goes according to the World Health Organization and their definition of puberty. So that brings the age down to 10.
Yes. And previously, the AAP, or the American Academy of Pediatrics, has stated there shouldn't be restrictions based on age. And so although we've put out there, and they have put out there in their best practice guidelines 13, because that is the data that they have, they also recognize that there's not data for less than that, but there are kids that have a BMI of 35 and 40 who are less than 13. There are a plethora of things that happen after surgery. But after surgery, they have diets that they need to stick to. So that means over the first 2 months, they're going to go from a clear liquid diet to a regular diet. After surgery, what we typically see is an average weight loss of 1 pound per day for the first 30 days. And what we typically see at a year is a 30% reduction in BMI. So if we keep in mind, if somebody starts at a BMI of 40, at 1 year, they are typically at a BMI of 28. And that is life-changing for children. So you have to remember, these are still adolescents. They still need to be with their peers. They still need to be interacting outside. And when they're at a BMI of 40, they're not doing those things. And that's pivotal for their development and their neurologic development at this age. And it's also just wondrous to see when it actually happens, to see them open up and engaging. So the only time that we use medications postoperatively is at their 3-month visit if they are not on track for what we know that they need to be at for successful continued weight loss. At that time, we can add medication. It's not something that is the norm. It's not the majority of patients, but we have that in our back pocket to have them be successful. And we follow them very closely after surgery. So as we said, that's 2 weeks, 1 month, 3 months, 6 months, and then a year. If at any of that time we see that we need to add medication, and Dr. Hahn starts to prescribe that medication, of course she's going to see them more than 6 months from then, because we want to make sure that we're having an adequate effect.
It's our pleasure, and please don't hesitate to reach out to myself or Dr. Bowen-Jallow at any time for any of your needs.
Absolutely. And, this is really a passion for Dr. Hahn and I. And so I think that shows in our work, and it will also show in how we treat your children.